in Michigan, and I'm currently completing a master's in clinical research at the University of Michigan. And I'll have Hannah introduce herself.
Hi, everyone. I'm Hannah Clode. I'm from the University of Miami, and I'm also in between my third and fourth year, and I'm pursuing an MBA at this time. And Tommy?
Hello. Thanks, everyone, for coming out. My name is Thomas. I also go to the University of Miami, so I'm a third year, and I plan to apply to IR this coming fall.
Awesome. And so these are our three faculty advisors or mentors who are on the call tonight. And we'll just have you guys introduce yourselves, maybe tell us where you're from, where you're currently practicing, and maybe a hobby outside of medicine. And we'll start with Dr. Kirkpatrick and then move from left to right across the screen.
So hi, my name is Daniel Kirkpatrick. I'm one of the new IR faculty at University of Michigan. I did my residency at University of Kansas Medical Center, and I did my fellowship at University of Colorado in Aurora. Boy, hobbies outside of this is a lot of family stuff. Board games, we'll say.
Dr. Tummala?
Oh, thank you. I kind of like all these University of Michigan peeps since that's my alma mater for undergrad and med school. So I'm pretty excited, but go blue, go blue. And so I did my residency at University of Wisconsin, my fellowship at Miami Vascular Institute, and I actually did a neuro stroke fellowship at UCLA as well. I'm currently at the University of Miami, and I kind of head up our vascular program. So happy to be here.
Yeah, so I have a picture of, I mean, you can look at my face now. I guess I could have sent you guys a picture where my face is in it, I suppose. My name's AJ Gunn. I'm an interventional radiologist at the University of Alabama at Birmingham. I was the principal investigator of the study that you guys are talking about tonight. I'm from South Dakota originally. I did my residency at Mass General Hospital and then my fellowship at Hopkins. I'm the director of interventional oncology as well as an assistant program director for the interventional and diagnostic radiology residencies. Outside, I mean, I'm a big Cubs fan, and I love to play golf. And so I really enjoy the weather down here because I can pretty much play year round. So excited to see what you guys have for tonight. So thanks for having me.
Awesome, thank you for everyone for joining us. And so before we go ahead and get started, this is the Transnational Journal Club. So we're just gonna give this a go and make sure the app is working. If you go to pollev.com/MatthewHenry787, this map should pop up and you should be able to kind of point to where, or click to where you're joining from. So we'll just give this a go to make sure that it's working well. So it looks like we got a couple answers so far. I'll give everyone just a couple seconds to do this. Awesome. Cool. Nice. I'm gonna take a picture of this. It's pretty cool. All right, so it looks like it's working. So we will go ahead and get started. And I will hand it off to Hannah to introduce this to us.
Yeah, so here's just the outline. We're hoping to take about an hour for this presentation. The beginning part is just going to be an overview. You can see the time breakdowns. We'll talk a little bit about SAE, how it's actually done, go over a couple of case examples, and then we'll talk about the study, of course. And then at the end, we'll have Q&A, and we'll definitely leave time for Dr. Gunn to discuss his thoughts on the paper. And we also want to make this interactive as well. So feel free to use the chat feature to ask questions, and we can address those questions at the end, or if it comes up during the presentation, we'll answer them then too. Okay, so let's get started. So here's another opportunity to get the audience involved. What is the missing link between the aorta and the splenic artery? We'll give you guys about like 10 seconds or so, and then we'll show you the answer.
So these are the word clouds. So if everyone's saying celiac, we'll stay big like that.
Right, yeah, the size of the word corresponds to the frequency of the response.
Yep.
Awesome. So it looks
Do
like,
we get to guess too, Hannah? Do we all get to guess?
of course, of course. So it looks like you guys nailed it on the head. It is the celiac trunk. Very good. Okay, here's the next one. The spleen protects you from what type of bacteria? I'll give you guys 10 seconds. Awesome. It's getting bigger, which means people are writing this. Very cool. Perfect. Okay, so the answer was encapsulated bacteria, which was the biggest answer. Next question. Pain from the spleen is commonly referred to what part of the body? And bonus points if you know the name of that phenomenon. Give you guys 10 seconds. Ooh, very nice. I see Kerr's in there. Yes, it is the Kerr sign and it is the left shoulder. Very good. Okay, and which virus is classically associated with splenomegaly? Wow, that was a quick response. You guys are on it. Yes, EBV is growing larger and larger because that is the correct answer, and mono, which is the same thing. I'll turn it over to Tommy to give us a little bit more anatomy review.
Okay, so here we see the answer to the first question. Highlighted in the box is the celiac trunk in the blue box, and then we see the splenic artery going behind the stomach towards the spleen. So if we go to the next slide, we see some fluoro pictures, which is what we're all here for, with numbering showing the way that it feeds off to the left side of the body towards the spleen, which is located near the tail of the pancreas. And the reason we picked this picture is because it kind of shows the feeding vessels that go along the pancreas to the spleen, which will be important later. So going to the next slide, yeah, we have the pathophysiology of spleen trauma. It's the most commonly injured organ in blunt abdominal trauma. And the reason that's an issue is because it's highly vascular because it filters the blood. So you can imagine that it causes a lot of bleeding whenever it gets injured. So a couple examples would be motor vehicle accident, contact sports, penetrating wounds like a knife or a gunshot, and then, lacerations or hematomas that just kind of cause a lot of bleeding that can be problematic after blunt injury. So on to the next slide. From the American Association for the Surgery of Trauma, we have this grading system for the different levels of severity of splenic injury, all the way from grade 1, which is a contained subcapsular hematoma, to a grade 3, which is where it kind of switches over to a more severe picture of splenic injury, and then grade 5, which is a completely shattered spleen. Another important note is that, when they do the CT to look for the degree of splenic injury, they'll also be looking for vascular injuries, and that includes things like AV fistula, a pseudoaneurysm, or contrast extravasation on the CT, which indicates bleeding from the spleen. So on to the next slide. We have a couple of CT images going from left to right, showing grade 1, which was that encapsulated hematoma, and then a grade 3 and a grade 4, which are ones that would typically be, we'll see later on for the triage of it, the kinds that would receive an SAE when they appear to the hospital.
And then moving on to signs and symptoms. So as Thomas pointed out, it's mainly about blood. The spleen has been hit, and now you've got internal bleeding. So you're going to have the sequela of internal hemorrhage. So those are things like obviously tachycardia, hypotension, lactate, and the patient's going to experience pain, obviously. And as we mentioned before, the pain can radiate to the left shoulder. And so here is sort of the meat and potatoes of how do you triage patients when they've got splenic trauma. So looking at the left side of the screen, you can see that if a patient is hemodynamically stable and they've got a grade less than 3, what Thomas was referring to before, you can use non-operative management. So bed rest, continued monitoring, and using like different blood panels just to make sure that they're not hemorrhaging internally. And then to the right of the screen, you can see that hemodynamically unstable patients need to go to the operating room. So they need to have splenectomies or have surgical intervention. And also that can occur if you have SAE failure. So then that leaves like the middle of the spectrum. And so the patient to qualify for a SAE has to be hemodynamically stable. And so that's like the first criteria. And then you can see here on the slide, different things like if you see the contrast extrav, if you see the pseudoaneurysm, if they have a grade 3, which is also included in the first box as well, they can also be eligible for SAE. And then as you can see also, if they have a large hemoperitoneum or a grade 4 and 5, they can also be included in SAE as well. So now I'm gonna explain a third-year medical student's version of how to do an SAE. So basically, you would access either the femoral or radial artery. You climb your way up to the celiac, and as we mentioned in the first slide, and you obtain your first angiogram just to like chart out your course. Then you push the catheter further along, and you identify where is the bleeding. After that, you figure out if you want to go proximal or distal, and then you embolize the bleed. Something to note here is that in our paper, Dr. Gunn used the proximal approach on all of his patients, and also he used femoral access on all of his patients too. And then breaking it down a little bit further, I found these cool pictures online. So proximal technique just means that you're proximal, right? So you're closer to the start of the celiac trunk, and you're able to basically stop the bleeds on multiple different fronts, which is what the right picture is showing, that there's multiple bleeders. So you can come proximal and then you can nip those in the bud earlier. And then something interesting on the left picture, that spleen is supramedial because surrounding it is a really large hematoma. So I thought that was a cool picture. And then you can contrast this with the distal technique, which is when you push further along in the splenic artery and go to a more like subselected artery and embolize there. And then something else to note, what Thomas was speaking about before, there are pancreatic feeders and also collaterals that continue the perfusion of the spleen. So you're not completely cutting off the blood supply to the spleen, you're just reducing the hemorrhage. And then for post-op care, so you want to monitor your patients, checking vitals, H&H, and urine output. And then something else is that, do you have to do re-imaging? And the answer is you don't have to. But as we were discussing with Dr. Kirkpatrick before, oftentimes your patients are going to have imaging anyways because, they'll be monitoring something else because the spleen wasn't the only thing that was damaged, for example. So imaging will most likely occur, but it's not technically required for post-op care. And then something else is whether or not to vaccinate the patients for asplenia. So the goal of SAE is to preserve splenic function, but it's debated whether or not you just vaccinate your patients against what we mentioned before, the encapsulated bacteria, or if they need it or not. So it's kind of up to the operators. Okay, and then moving on to possible complications. So this is picked up from a paper from the American Journal of Surgery. And you can see here that there are different types of complications that occur. And then you can see the complication rate, like the frequency. So this was 11-year retrospective review, and 88 patients had undergone SAE. And this is the complication rates from that cohort. So you can see things like infarction, abscess, contrast-induced insufficiency, cyst, pleural effusion, coil migration, fevers. Those are some of the more common complications. Okay, so I've been speaking a lot. Let's see if you guys learned anything. So here's our first case. You're in the trauma bay on a quiet Friday night. People nearby chat amongst themselves and whisper, "Wow, what a quiet night." And immediately the trauma radio fills with incoming patients. So the EMS gives you these details for your first case. So you've got a 60-year-old female, pulse or blood pressure 100/70. She's breathing at 18 breaths per minute, temp is 99.9, heart rate is 100. This is the CT that you get. What is the best course of action? Surgery, serial H&H and close monitoring, or SAE? You guys can vote now. Okay. Let's see how we did. All right, okay. So majority picked SAE, but it wasn't a clear cut. So the correct answer is SAE. So the reason why is because this patient is hemodynamically stable, which is the major criteria. I tried to make the vitals as stable as they could be. And then you've got the contrast extravasation coming up with the arrow there, and the large hemoperitoneum surrounding the spleen. And so then here are follow-up pictures. The middle one's pointing to the bleeder, and then C is showing after the coil deployment.
So here we have yet another case. It's a 33-year-old male coming to the ED following a motor vehicle accident. He is hemodynamically stable and undergoes a CT of the chest, abdomen, and pelvis, which reveals a vascular injury and active contrast extravasation confined in the capsule. IR is consulted and performs an arteriogram. So here's the picture of what we see. Notably on the side, there's multifocal extrav of the contrast. So what do you all think is the next step? Do we do a proximal, distal, SAE, or do we need more info? So I'm going to vote too. And then, good. So it might have been a hint that, in the paper, all of the technique was a proximal SAE. But notably what we were trying to point out with this is the multifocal extravasation of the contrast. Because it's kind of all over the spleen, doing a proximal technique is obviously preferable. That way you can embolize all the different areas of like active bleeding, as opposed to more distal where you might not catch all of those different areas.
Okay, so thank you, Thomas and Hannah, for giving us that awesome overview of SAE. We're now going to move into the discussion of the manuscript. Manuscript was completed at the University of Alabama, Birmingham. Dr. Gunn, who's on the call with us tonight, he was the PI. And the title of the study was a pilot randomized control trial of endovascular coils and vascular plugs for proximal splenic artery embolization and high-grade splenic trauma. But before we actually dive into the study, I think it's important to note here that this is a pilot study. And so that a pilot study has different goals and objectives of your everyday clinical trial. So before we get started, I'm wondering if people have any ideas of what are some purposes of a pilot study. And so you should be able to go ahead and just type in your answers here. Yeah, so I'm seeing feasibility is the biggest one, and that's exactly right. So a pilot study is a small scale test of methods and procedures to be used on a larger scale, and the primary purpose of it is feasibility. And you can assess feasibility in any different type of the research study, whether it's screening, recruitment, randomization, retention, et cetera, et cetera. And basically you're asking yourself these questions: can I recruit my target population? Can I randomize my target population? Can I keep participants in the study? So you're trying to determine if down the road you can conduct a clinical trial on this intervention that you're looking at. What is really important to remember here is that these are not used for hypothesis testing. And that is because there's the power analysis done to determine the sample size of pilot studies isn't done to detect a clinically meaningful difference. It's just done, the sample size is done to see if you can basically conduct a study down the road. And that kind of brings me into my next point, which is the misuses of pilot studies. This is actually pretty common if you look into the literature. Most common misuses include attempt to assess safety and tolerability, to seek to provide preliminary tests of a research hypothesis, and estimating effect sizes for power calculations of a larger study. And that last bullet point is probably the most common, but also the most important. And I'm going to kind of walk through it with this table here, because this can be a little technical. But if your pilot study has an effect size that is really, really high, it's important to remember that, again, this effect size wasn't done in the study that was completed to determine a clinically meaningful difference. And so if your effect size is really high, when you then go on down the road to do a power analysis for a clinical trial, that power analysis will show you that you don't really need that many subjects. And the potential follow of that is a difficult to detect effect size in your actual clinical trial. So basically you've conducted a clinical trial with an inappropriate power analysis, and you're kind of doomed from the beginning. On the flip side, if your pilot study effect size is really low, when you go to do a power analysis for a clinical trial, that power analysis is going to show that you need a lot of subjects to detect the effect size that you're looking for. And so the potential fallout of that is that you're going to conduct a really expensive clinical trial, but also you might kind of run into this unethical risk of exposure of patients for an intervention that you're not really even sure that works. So I guess, because this is a pilot study, I thought this would be a good opportunity just to remind everyone kind of the goals and objectives of pilot studies. And you'll see this a lot in the literature as you actually look for it. So back to Dr. Gunn's study. So this was a pilot study. It was at a single institution, which is a level 1 trauma center. And they're doing a randomized control trial of endovascular coils versus vascular plugs. So what are these embolic agents? So the coils are probably the most common that you see. And they involve a distal anchoring coil that is kind of stiff at the distal portion, and that helps the coil actually anchor in the vessel. And then as you move more proximal, the coil becomes a little bit more malleable and softer. And that allows the secondary packing coils to be placed behind the anchoring segment. And these packing coils are quote unquote liquid metal. They're really malleable, and it really helps the coils to conform to any vessel size and achieve hemostasis. The other embolic agent that they looked at were vascular plugs. These, you typically only need one vascular plug, and they're self-expanding plugs that assume a pre-specified or determined shape. There's 4 different types, at least of the AVP. And in this study, they looked at types 2 and 4. So those were the 2 embolic agents that they were comparing. So who was included in this study? So it was all adult patients with grade 3, 4, or 5 splenic injury, and patients referred to IR for proximal SAE. And I think this is a really important point here, is that at this institution, all hemodynamically stable patients with grade 3 to 5 splenic injury who are selected for non-operative management are referred to IR for consideration of a SAE, regardless of direct signs of vascular injury. And I'm not sure how common that is across the entire country, and that's something that maybe we can discuss with Dr. Kirkpatrick and Tummala later. But because at this institution, they had this protocol in place, it really provided them an opportunity for a large patient sample size to select from. For the exclusion criteria, this is pretty standard. Not candidates for proximal SAE, unable to provide informed consent, non-English speaking patients, prisoners, pregnant or breastfeeding women, and uncorrectable coagulopathies or immunocompromised patients. So these patients were approached for consent shortly after obtaining informed consent for the proximal SAE. There was no blinding done, and this was an intention to treat analysis. The primary outcome was feasibility of enrollment and follow-up. And again, this is in line with the pilot study, which its primary goal is to assess feasibility. And the authors determined accomplishing this primary outcome as enrolling greater than 50% of eligible patients, or adequate follow-up of 70% of those enrolled patients. The secondary outcomes were basically to identify potential primary outcomes for future trials, that being primary technical success and secondary technical success. Primary being hemostasis with assigned embolic agent within 15 minutes, and secondary being the same thing, but just with a different embolic agent than the one assigned. And then additional outcomes that the authors looked at were technical parameters, including duration, time to hemostasis, radiation dose, etc. So I mentioned that this was an intention to treat analysis. So what are the benefits of an intention to treat analysis? I'll give people a moment to answer the question here. All right, we're gonna move on and see. Okay, yeah, so most people said A and B only, but there was a third of people that said all of the above. And so the reason why the correct answer is A and B only. The reason why C is incorrect is because in an intention to treat analysis, the subjects are analyzed based on the intervention that they are assigned to, not the intervention that they actually receive. So if a subject is assigned to a certain intervention, in this case, let's say a vascular plug, but they end up receiving coils, they're still analyzed based on the vascular plug that they were initially assigned to. So that's the difference. So this is the consort diagram from the study, which is basically just kind of a flow chart of how, or like the numbers of patients assessed for eligibility and consented. So as you can see here, 50 patients were assessed for eligibility, 48 patients were randomly assigned, 24 to each group. 23 received the allocated intervention. There was a crossover of one patient in each arm, and then one patient in each arm was excluded due to invalid consent. And 23 patients were followed up, or 23 patients in each arm completed the follow-up for 100% follow-up. So based on this diagram, did the investigators achieve their primary outcome? Give people a couple more seconds here. Okay, so again, 2/3 said yes and 1/3 said need more information. In this question, the correct answer is actually yes, because remember the primary outcome was assessing feasibility of enrollment and follow-up. And here, the investigators demonstrated a 92% enrollment with 100% follow-up, which far exceeded what their initial criteria or what their initial threshold was, which was 50% enrollment of eligible patients and 70% follow-up. So just based on this diagram alone, we can determine that they achieved their primary outcome. And now I will hand it over to Tommy to discuss the baseline characteristics.
Yes, so right before I jump into that, I just wanted to go ahead and ask the doctors if they had any thoughts that they were holding on to during this and get the expert opinion. See if there's anything that they wanted to say throughout it.
I don't think I have an expert opinion, but I was interested in kind of weighing in on to see. So we know kind of how it works at UAB, but I was going to ask Dr. Tummala kind of what his experience was as far as do you automatically get referred any splenic injury that's 3 to 5? Because I feel like at least in my experience in places where I've been, it's varied. So sometimes somebody will have a grade 3 laceration and the team will think, oh, they look pretty stable. We'll just kind of watch them and see how they do. So sometimes even with higher grade ones, I've seen them kind of sit on them and see if they do okay, which I don't necessarily think is wrong. But I was curious. I thought it was actually really cool that you guys have such a streamlined setup that you just automatically get those referrals straight away.
Yeah, thanks, Daniel. Yeah, I mean, we have a level 1 trauma center, just like, AJ does. It's about almost 1,000 beds total. And our trauma surgeons are very aggressive, in terms of embolization. And, it used to be that they were, hemodynamically stable or kind of borderline. and then they saw, you know, grade 3 to grade 5, and then it'd be something we'd embolize. Now I'm starting to notice that they're asking us to do a proximal embolization on patients who are sometimes even grade 2. You know, and what they're doing is they're basing it really on their clinical assessment at, you know, as they're watching the patient over a few days sometimes.
Mhm.
If they notice that there's any drop in the H&A, the hemoglobin and the hematocrit, if there's any kind of, you know, hemodynamic instability, so to speak, if they've got blood pressures that are going up and down, or if the patient has a lot of other multiple, you know, has a lot of other injuries, because we tend to see basically penetrating injuries. That's the biggest thing we see: knife wounds, gunshots, and so forth. And so if they see any of that, they are quick to ask us to do an embolization. And a lot of times we're like, really, you want to embolize this? And they're like, yeah, we think it'd be better. And so I think for us, you know, since we're such a busy trauma center, I'm sure just like AJ's place, and I don't remember what University of Michigan was like, because I mean, that was in the days of Dave Williams when he was like a young guy, you know what I mean? So I'm kind of dating myself here, but the thing is though, is that they are very aggressive, and we do see the majority of them at this point.
Mm-hmm. Very cool.
You know, I'll let you guys go through the presentation. I'm writing down my thoughts. I think there's a slide there at the end for me to kind of add in a little bit, but you know, just to highlight one thing, this is the issue, right? Like, this is why we need to ask the questions, because there's an extraordinary amount of heterogeneity that exists about how this is practiced. And, you know, are we over embolizing or are we under embolizing? And I don't think anybody has any idea. And that's kind of how we got started down this path, but I'll let you guys keep going and I can round that out at the end a little bit.
All right. Thanks for the discussion, and feel free to jump in anytime. But as a student, that was good to hear, because, you know, in looking up this presentation, it was interesting to find like the different protocols between hospitals. So I'm glad you guys touched on that. Just getting back to the paper, yeah, we're going over the baseline characteristics now, which may not be the first thing everyone looks at when they pull up a paper, but it's obviously very important for our pilot study. And, you know, it's important for this one that's like a kind of pioneering a new area of research. So here we're looking at the mechanism of injury, which, as we can see, is mostly motor vehicle crashes, followed by falls and assault, so all blunt trauma. Going on to the next slide. The paper used the injury severity score, which, as we can see, about 78% of all enrolled had a ISS of greater than 15. So go on to the next slide. The injury severity score is something that comes to us also from the AAST. A grade of above 15 is a severe injury, and it just takes into account the different kinds of injuries that patients can come in with, based on like locations of the injuries and severity in each location. And then this one's really important because this is showing that all the patients enrolled were hemodynamically stable, which is, of course, one of the main criteria for SAE. And notably, yeah, there's no major hemorrhage protocol called on any of the patients if you read the bottom line. So this one just shows that for the procedure, which is also, you know, very important, there's no major differences in the groups between like radiation dose, duration, contrast amount, no significant differences. So.
Okay, now we've got table 3, which is the study outcomes, what we've all been waiting for. So as you can see, on the left is the coil and on the right is the plug, but you can see that both achieved primary technical success, and they all achieved stasis. And on the next slide, we can see that there was a grading system by the SIR. And if you go to the next slide, you can see what that grading system means. This is something that I learned. So A and B are minor complications, and then C and on are the major complications. And as you can see, there was one major complication out of everyone who was seen. So this is transfusion needs. So this is really important because you can see that no one needed transfusion in the first 24 hours. And on the next slide, you can see that everyone was discharged home. So the clinical outcomes in terms of technical success and stopping hemorrhage were phenomenal. So now we go to the question of what are some of the limitations of the study? So you guys can answer and we'll create a word cloud. Awesome. So you can see that single center is getting bigger and bigger, which is very true. Awesome.
I'm just minimally offended whoever said that either my institution or my hypothesis was the limitation of the study, but that's okay, I guess.
Maybe that it's a pilot study, so you can't be testing a hypothesis. Maybe that's
I'm just kidding. I'm just kidding.
So some of the limitations that were mentioned in the paper, that it's a single center, it is a pilot study, there wasn't blinding, so patients knew what they were having done, and the physicians knew what kind of device they were implementing. The implementation of the actual embolic was operator at the discretion of the operator, and if something happened where the stasis wasn't reached, I don't know why I'm drawing blanks here, they had to switch to different types of embolics, and that's obviously up to the judgment of the attending. And then you can see some of the other limitations. Early hemostasis missed, and also there was a 15-minute time point for hemostasis from the time that they started the procedure to when they were able to achieve stasis, and if not, then they moved on to a different intervention. So now we can ask Dr. Gunn to give us all of his thoughts that he's been writing down and give us some of the major takeaways from the study, and also some of the things that you learned as being a PI on a RCT.
Yeah, thanks. So I would say, so for major takeaways, there's three things about this. Number one is that it was feasible. Prospective trials in the trauma population are inherently difficult because of consent issues and timing issues and all of those other kinds of things. Now, we had an advantage in the sense that, all of our patients were going to be hemodynamically stable, right? Most patients could consent for themselves. We don't come in, typically in the middle of the night for these kind of cases. We do them within 12 hours unless, clinically they're worried about the patient in some way. So had a little bit of an advantage there, but, regardless, the fact that it was feasible was a good thing, to prove, because if it's not, we couldn't randomize people, enroll people, then you're done. And that's just kind of the end of it. Number two was that, and this kind of goes to the point earlier, is that proximal splenic artery embolization, regardless of the grade of splenic injury and regardless of whatever other injuries in the spleen that there are, it worked, right? I mean, we had 98% or like 96 or 98% splenic salvage. And that was one of the things that, when I hear, people, I go distal for this, I go proximal for this or whatever else. I mean, how we trained, we just did proximal for everything, and like, why am I can do this case in 10 minutes and I'm done, and I know clinically, and I know when everybody talks about whatever they do is the right thing, right? Obviously you'll see that in IR surgery, you see that, all that kind of stuff, but it was nice to see with a prospective, data set that, yeah, what we were doing was really working for patients. I think that was, and so overall, one thing I think you could at least take away and start instituting in your practice from day one, if you really wanted to, is that proximal splenic artery embolization works, period, end of story. And then the third thing is that we really wanted to find some sort of, you talked about this in your presentation, we really wanted to look and say, okay, what could we power, what would be a clinically relevant endpoint that we could appropriately power to do a study? Because like you guys mentioned, if the efficacy is very high and there's no two big differences between the two, it's not a great question to evaluate, right? Because the number needed to treat is going to be extraordinary, in which case your cost is going to go up, in which case nobody's going to fund you, right? So for example, if we're 97% successful with treatment A and 94% successful with treatment B, why are we evaluating the difference between 3 percentage points, right? So we need to find something that's clinically relevant. And so, we think using a Bayesian analysis, we think that looking at primary technical success, which was how we defined it, which was number one, could you deploy the embolic that they were randomized to? And did you get stasis in the mid-splenic artery in the first 15 minutes without having to use a secondary embolic agent? If you could do those two things, that was primary technical success. And what we found is that, the primary technical success with coils was an 80% likelihood better than it would be with plugs. And so, we use that to power our next study, which is probably funded. I don't know. I mean, I think it is. But it's not like final coming through. But and that's going to be, a larger multi-center study across the country to follow along with that. So that's really the third thing, is that we really wanted to find something to say, hey, is this clinically relevant, right? So we looked at contrast volume, we looked at procedure time, radiation dose, some of these other kinds of things. Because when it came down to it, complications were overall very low. There's like 3 complications in the whole study. Splenic salvage was very high. So looking at those kind of clinical parameters, we thought wasn't going to be very fruitful. And that's what we found. Even on our preliminary research, that's what we found. We didn't really think that was going to be a good thing to study, kind of going forward. So as far as, being a PI, I mean, I don't feel totally competent in doing this because I really, rely on so much mentorship. I mean, honestly, I almost feel like people are doing the work for me. But, here I am, I guess. And so my frustration generally is that in interventional radiology, we get distracted with new procedures and new devices a lot, right? Like, hey, here's this catheter. It's 2.1 French versus 2.0. And then all of a sudden, someone writes a paper and here's that. And I can see Srini nodding his head. It's like, here's the first 13 prostates done with this 2.2 catheter on a Thursday when the moon's full, right? And they send that out. And it's like, it's case series after case series after case series. And I just, after publishing enough case, stuff like that, you just kind of go, am I moving the needle at all? And that over the last 2 or 3 years has been a real problem for me, is I was like, am I really moving the needle? And I've kind of changed the questions that I'm asking. Even if I'm doing retrospective stuff, I'm trying to say, like, is anybody written about this? And is this a clinical question that we need to answer? So I really feel like prospective data in interventional radiology is where we need to start focusing. And that involves registries, that involves, establishing clinical trial networks and all of these other kinds of things that we don't have yet, probably compared to, say, surgery or medical oncology. And so we're starting there, but we're a long ways off yet. So that's really one thing. But the second thing is that it answers a clinical question, and so how this all started was that I was on call and my fellow called me and said, hey, we got consulted on a splenic trauma overnight. I didn't call you because there was no active extrav. And so that's why I said no. And I said, well, that's not how things work, right? And so I called the surgeon that was on call and I said, listen, I'm going to do some education with him and with our group. And, we're going to take care of this today. And he said, for him, what had happened is when they had their last site visit from the ACS, they had actually got dinged for taking out too many spleens, right? So they do kind of chart biopsies. And so for us, his thing is like, we kept getting all these infarcts and infections, and they just felt like, embolization with IR was kind of fraught with all these problems. And so because we were meeting on a clinical need, it allowed us to sit down together, develop a protocol that was mutually beneficial for them, right? Because now they're going to get back in line with what the ACS wants them to do. And with us, it increased the number of procedures we are doing by almost 3-fold as far as splenic goes. And then once we did that, it established a clinical working relationship and allowed us to kind of ask the question, what do we want to know about splenic artery embolization, right? And so when you look at the data that's out there, it's you know, do I do 2s? Do I do 3s? Do I do distal? Do I do proximal? Should I include 4s? People are all over the place, as you saw before, and there's just not a lot of good, I mean, there's prospective data out there, but it's mostly case series. There's meta-analysis out there, but you know, then it starts to get really heterogeneous, right? Like they were comparing all 3, 4s, and 5s, or all 3, 4s, and 5s without extrav, 2 extrav. And so the nice thing about this was that we were actually answering something that was in our clinical practice. And I've actually had partners now that used to be only distal, and now they're like, well, wait a minute, after doing this trial, now I realize that proximal's fine. And we've changed their practice because we can prove it with data, right? And so now we have this really good working relationship with trauma where we don't take spleens out that much anymore, right? Unless the patients are hemodynamically, you know, unstable. So I think, you know, answering a clinical question, you know, and you can see kind of the debate that arises from there. And then the other thing that I think that I learned from this a little bit was and expressed to you guys is like kind of all the stuff that's going on in the background, you know, with this. So initially we wanted to do a registry. And then they said, you know, the companies, everyone we approached was like, we don't want to do registries. They're like, can you do something prospective? So we set up something small and prospective and got some funding through the institution. That led to us getting some funding through industry to do the larger trials. Simultaneously, while we're doing that, we're doing a systematic review and meta-analysis to try and find endpoints for a larger trial. Simultaneously, while we're doing that, we're also looking to design, you know, a trial looking at just grade 3s, right? Because I think most of us would do 4s. Most of us would do 5s. So we kind of sit there and say, well, is there equipoise between grade 3s without an active extravasation? And so we're designing that kind of trial right now. So there's all these things going on in the background that just isn't this trial. And you can see kind of how things, you know, sprout out from there. So those are some of the things that I learned from going on there. And the other 2 points that I would make is that it's really hard, you know, and that's why not a lot of people do it. I don't mean to be critical of like, hey, you know, we need to do prospective data. Yeah, we do, but it's like super hard. This was like 2 years just to get this up and off the ground and to get to 50 patients enrolled and to write it. And then the other thing I thought was really interesting is, you know, you talked about bias. Without blinding, bias is actually pretty real. You know, like as an investigator, you want it to be successful, right? So, I mean, those kinds of things when you're thinking about, oh, is this a complication or isn't? Those kinds of things, when you're not blinded to it, you know, you really have to fight back against that. And that's something I hadn't really realized. I think the difficulty in doing this is something that I hadn't really realized, the amount of bias that can be there. I hadn't really realized, and then learning to ask a really focused question like I feel like we did. And that's the other thing, is that sometimes people come and say, is embolization good? Well, that's not a focused question, right? Like the real question is, in hemodynamically stable patients with grade 3 lacerations without active extravasation who are selected for non-operative management, does splenic artery embolization improve rates of splenic salvage compared to observation alone? That's a focused question. And then you can start working around that instead of, does splenic artery embolization work? And I would say that, you know, the bias, the difficulty in doing it, and, you know, asking a specific question were things that I really learned, you know, during this process. So I'm happy to, I know that you guys, Daniel and Srini are going to talk a little bit. I'm happy to kind of chime in if people have questions though. So those are my thoughts.
I had a quick question for Dr. Gunn. You know, I feel like, you know, we're, as a new specialty, one of the kind of the weaknesses inherent in our kind of our paradigm is the lack of kind of prospective data and the kind of the scientific rigor that most other clinical specialties have developed over the course of the last, like say, decade, you know, maybe even arguably 50 years. What will be the impetus for us to kind of drive? I know it's a lot of work and effort, and we're not necessarily kind of driven in this nature, but what is it going to take for our specialty to kind of transform in that rigorous kind of scientific method? What do you think we need to do?
You know, it's going to take, you know, individuals like yourself. And like when I was a medical student, you kind of go to research stuff and people are like, oh, it's you guys, but it really is, right? It's really getting you know, a critical mass of interested individuals who are interested in pushing this forward. And I think society-wise, people are, you know, we're getting there. We talk about it a lot. There really is some motion inside the society to set up a trials network and those kinds of things, because, you know, when oncology wants to set up a trial, they just send out a thing. And I mean, literally they've got like 10,000 patients in a month. That's what it feels like, right? And so the power is always really quick. So it takes interested individuals. It takes investment from institutions and societies to invest the time and resources to train those individuals to do it, because it's not easy, to do. And so those are really the things, is kind of getting that critical mass of people. There's a question on the chat there. Blinding the study, you could blind the study in what you would do is you blind the study so that the patient doesn't know what they're randomized to, right? We didn't even attempt to do that, right? I don't think the patient really knows, but you could say, okay, you're going to get one of these two things, but you don't know what you're going to get. And then as far as blinding, you wouldn't blind the operator, but you would blind, for example, for me as the PI, I would be blinded to what the patient got. Right. So for example, the interventional radiologist, so one of my partners knows obviously what he or she's giving the patient, but the patient doesn't know. Right. And then I don't know when I'm collecting the data gets entered by a research coordinator. And then I'm blinded when I'm doing data analysis, I'm blinded to what everybody got. So that's how you would blind it.
If I could just add to one thing, AJ, by the way, great paper, great information. I mean, just one question I had before I give a comment. Are you guys doing proximal splenic embo even in the setting of active extrav during angiography, et cetera? Is that what you're doing as your protocol in your institution?
Yeah, I mean, I think yes. I mean, that's the short answer. If your patient population is primarily penetrating, I could see how you practice a little bit differently. You could look at ours. I mean, almost all of them, if not all of them, were blunt trauma. And so my thought about this is that, the spleen's getting squished. And so in my experience, it's very rare to have like one focal injury from a knife wound where it's bleeding, in which case I just need to depress the whole spleen needs to just be given a chill pill for a little bit, which is what proximal splenic artery embolization does. The one splenic rupture I ever had, I got goaded by one of the trauma surgeons. They're like, oh, just embolize the top there. There's the little bleed. And I did it. And I just think there's injury there we don't see in blunt trauma. And I think all that did was redirect the high flow blood to the other areas that were less injured. And then it ruptured 3 or 4 days later. So yeah, that's our practice.
And also, which is interesting that they ask you to do that, because that's why they scan these patients a few days later as well, or within a week, because they know they're going to see other injuries to the spleen in different areas or things that manifest. The other thing is getting back to the question of when are we going to start doing good studies, in addition to the one you just did. I think as a society and as a whole, we are not good at forming huge databases. If you think of just the basic uterine fibroid embolization, which has been around since the late 1980s, it started a little bit, but it never really went anywhere. If you really look at, vascular surgery, vascular medicine, cardiology, and so forth, they have these huge databases where a lot of sites get involved and contribute data and so forth. Whereas I feel like with us, we're basically you have a lot of lone rangers, kind of doing quality work at different institutions. And like AJ said, it is a lot of work. It is painstaking. It's exhausting. It requires you to do this after you've worked, a 10-hour day. And, if you have kids, wives, husbands, boyfriends, et cetera, it takes away from them as well. And it requires them to have buy-in. So I think that is one of the difficulties in publishing good studies. But, more importantly is like AJ said, we don't get 10,000, if you're a cardiologist and you're studying hypertension, you get like 10,000 patients, it seems like within like 2 weeks, and you're ready to go with like huge data sets.
Srini, it's Joji here. Yeah, one of the things that I think I've learned from going to some of these multi-disc conferences is the importance of level 1 evidence and data. So whether it be ISET or VIVA, things of that nature, you see that kind of just like, of course, you have to do this. And so it's just kind of the rigor and the mindset. Whereas if you go to SIR, that's not necessarily our day-to-day discussions, like, oh, look at this cool procedure or extreme IR, as opposed to kind of rigorous data. That's almost like the place where people don't go to. So it may be a little cultural too, shift that we need to have. But I think, showcasing the work that Dr. Gunn has done, and hopefully others will continue to do, will kind of propel our specialty to not just innovate, but to validate what we do.
It's funny, and I'll just get on my soapbox here, and you guys will sense that I'm still, hurt by this, is that, I sent this to radiology, and radiology had really good reviews. Their only thing is we just don't know that we're the right journal for it. It's a little like too technical to IR, we think, for radiology. So I sent it to JVIR and I thought this is going to be a shoe into JVIR, and JVIR like rejected it out of hand. In the same month when JVIR rejected it out of the hand, the CME article for JVIR was a 35 patient retrospective series evaluating survival, predictors of survival with patients with liver dominant metastatic breast cancer after radioembolization. And I'm like, why? You got to be killing me. You know what I'm saying? I agree with you. It's cultural in a way, you know, I couldn't even believe it. It was the night and day to that to me was like, you're not appreciating what this represents versus, you know, that 35 patient retrospective series. And I'm not saying that that's not valuable in some way. I'm just saying it does represent a cultural problem we have in this society.
Yeah,
So yeah, that's part of the reason why we built this transnational vascular interventional journal club, is to specifically focus on prospective and randomized data, and so that we can kind of have that as our focus, as opposed to, like you said, kind of like anecdotes and kind of, oh, these are cool pictures or pretty pictures. So hopefully that will be the kind of the message moving forward.
And Joji, you know, you can also focus on meta-analyses. I mean, that's a big thing that's happening right now, and it's really helpful with how much, you know, how heterogeneous a lot of the data and the studies are out there for really big questions, you know, like AJ pointed out, and I agree 100%.
Yeah, no, I agree. I mean, meta-analyses are valuable if the data is quality, meaning it's mostly RCT data. The challenge that I see in some of our meta-analysis, it's still a lot of retrospective analysis. So it's garbage in, garbage out sometimes if you don't have good, like kind of the crux of it should be still kind of prospectively gathered information, core lab adjudicated, you know, et cetera.
So I kind of had the question. We're kind of talking about like the shift, hopefully, in interventional radiology to, you know, collecting prospective data and doing these randomized control trials. And we kind of touched on it, and so did Dr. Gunn and Dr. Tummala, kind of about the collaboration with the Department of Surgery. And that seemed like something that was really important for this study to be successful. And so I was wondering, you know, if Dr. Kirkpatrick or Dr. Vatican-Cherry, or, you know, the other attendees, if they want to chime in as well, just kind of talk about how they are establishing these relationships with the Department of Surgery and, you know, using that collaboration in order to carry out these studies, because it seems like we need a lot of buy-in from them and, you know, I guess, you know, goodwill with them in order to conduct these studies.
Well, you know, let me just give one comment. I don't think you need buy-in from them. I think you'll be surprised how little a lot of them know of what we actually do, you know, and what we're capable of. I mean, I think, you know, each specialty understands what we do for them in very niche kind of, you know, techniques, treatments, therapies, et cetera. But you'll be amazed how many physicians you talk to and they'll be like, oh, really? Oh, I kind of knew that, but not really. And I think what AJ did was really kind of talk to them about, look, we can make this therapy much more scientific and much more consistent in terms of whatever the guidelines are out there. And I don't want to talk for AJ, but I mean, that's kind of what I took away from what he was talking about.
Yeah, so building these relationships is difficult. I think one of the best things that you can do just regularly to make it a habit is immediately call them after the procedure. Really establish a dialogue with these people and be their friend. And don't come to them asking for things or looking for things. Just really show them that you're not a proceduralist, that you are a clinician. And that relationship will naturally unfold on its own, because naturally, if they're friends with you, they're going to call you and say, hey, I have this difficult patient. Can you help me out? And that's how you start building those relationships. And that is how you can then launch things like this, which Dr. Gunn, I think this is a great study. I think this is really exciting. Something that I talk to people all the time about is that, you know, it's fun working in a data-free environment as an interventionalist, but at the end of the day, I think that the push of at least my lifetime and hopefully the lifetimes after me is to push this kind of from a data-free zone to these things where we can plop out a paper and say, the data shows that coils are better. The data shows that plugs are better, whatever that may be.
Yeah.
Okay.
Go ahead.
No, yeah, I guess
no, I mean
that how I couch this, and this isn't just research, but it's also kind of practice building. How I usually couch this to people is that even though we really want to puff out our chest sometimes in IR and be like, these are my patients, they're also my patients as well as yours, because we don't want to get, just like Dan was saying, we don't want to get kind of like put in a box as a technician. And I agree with that 100%. But how I usually tell people is you gotta couch yourself to them as an extension of their practice, because we're a referral, and so, for this study, they had a problem, right? They had gotten a ding on their last level 1 trauma site because they were taking out too many spleens. So we were a solution to a problem they had. With our oncologic stuff, I'm a solution. I'm a non-operative solution for their non-operative patients that they can offer them, right? And when I couch it that way, I feel like we get more buy-in because they don't feel like, hey, you're trying to encroach in our space or take stuff from us. It's like, we're just trying to help your patients and find solutions that you guys don't necessarily have in your toolbox. And that's typically how I approach it.
I'll have a little bit different view in some ways. One of the things that I've started doing more and more so is just, following these patients, right? If I do an embo, it's a GI bleeder, or embo for whatever, trauma, whatever it may be, I'll just bring them back to the office and see how they're doing. I'll sequentially follow them. So I think that's really helped, because you see I think there's 3 things when you're looking at a trial and comparing things, right? Compared to gold standard, right? So it's safety of what you do compared to the gold standard, the efficacy of it, and then ultimately the durability. So what we need to do is look at those 3 things and compare it to whatever is either the historical standard or the kind of the gold standard as based on whatever kind of standards of practice. So for example, AJ's kind of looked into blunt trauma and showcased, hey, this kind of proximal embo may be arguably the new gold standard. Now the question is there something else that's going to push that new gold standard? You're going to use this gold standard, the partial embo for blunt trauma, and compare it to something else, perhaps. I mean, so I think when you follow these patients over 1 year, 2 year, 5 year, 10 year, you'll see the downstream benefits. Like if you avoid a splenectomy, potentially those encapsulated organisms or whatever can be the problem that can happen to these patients, whether it be strep pneumo or something of that nature, you potentially reduce that event. And that could be downstream 10 years, 20 years down the road. You don't know that. So these are things that we need to kind of think about. So again, I think it's safety of what you do, the efficacy of what you, and the durability when compared to the kind of historic standard or a defined gold standard in any trial that we do in a prospective fashion.
Awesome. So it is now 9 o'clock. So are there any other questions from any med students or any kind of final points from the attendees before we disperse for the evening?
Yeah, I guess I had a quick question. My name is John Goss, and I'm a med student at Creighton, just kind of a new convert to IR. Just found it an amazing field, super excited, something I'm ready to pursue kind of the rest of my life. I guess just one way, what would be a way for a med student? I've obviously signed up for like SIR and kind of looked through those opportunities, but to get involved in kind of this research and kind of moving the field forward, because it's so interesting that you'd be able to just kind of push it in kind of this whole new field. When I'd love just ways to get involved as far as that goes.
I actually have a medical student from Oklahoma State University that works with me because he found me through the mentor match program, through the SIR, and he just had an interest. He could do something that I couldn't do, and so that was really helpful. So that's one thing I would say. Think about that mentor match program and just kind of see if somebody, even locally or somewhere nearby. The other thing for medical students is they do have kind of like summer internships. Obviously they didn't do them, this year, but they do have, some opportunities that way to go, potentially to other, institutions for 4 or 6 weeks and do research with people who have, established, practices and labs. And so I had a student that got accepted into that last year. Obviously wasn't able to go because of COVID. So those are just a couple things off the top of my head.
Yeah, John, real quick, I can say that the SIR Medical Student Reserves is something that I've gotten involved in pretty heavily over the past year. And that has been an awesome opportunity just to be involved in a bunch of different projects, to learn about the different procedures and the different opportunities for IR. So I highly, highly, highly encourage you to join that. I think both Hannah and Thomas and Austin we're all pretty involved in it. So doing that is a great opportunity to meet other students from around the country, around the world, while also learning about IR and then meeting attendees as well. So.
Yeah, I have to echo that. Lindsay Arndt is the head of the SIR reserves for med students, and Austin, maybe you can get CC, we have the conversation, we can get you figured something out. So we're able to kind of, I know, even Dr. Gunn has kind of reached out to me. We've been able to kind of collaborate with students. So I can usually find somebody somewhere that can kind of work with you. So maybe shoot me an email. We'll get that going. So if there's an interest, we'll find something and close the loop. So even Matt, if you can give him my email. But I want to echo that this is really I'm surprised, AJ, that it wasn't accepted by some of our journals, given the prospective rigor of the data.
Yeah.
Because those are the kind of things that have impact factor, right? So when you're looking at impact factor, really, if you look at the New England Journal, they're not going to publish a lot of retrospective case series, right? They're publishing things that are relevant to time, such as a COVID, Pfizer, and Moderna, but they're all mostly level 1 randomized trials, even those, right? Even in a short amount of time. So this is exactly what improves the impact factor and relevance of a journal. So I'm a little bit surprised that wouldn't be kind of at the forefront of those journals. But sometimes it's also good to publish this in non-interventional journals. So as Dr. Tummala said, we have a branding problem. So this would be important to publish in Annals of Surgery or the trauma literature, so that they're aware that this should be kind of the standard, perhaps a standard practice. And that way, for us to change our practice pattern because of human bias takes a long time, even with level 1 evidence, right? So and I've heard a few people say it takes 17 years to change practice pattern because we're human and we know what we know and we don't like to change it, even if the data is compelling. So I think that's something also to consider as we do these trials, AJ. It may not be a bad idea that it's published in their literature to showcase, hey, we're here, we're in the game.
Okay, are there any other final questions or thoughts? Thank you so much for everyone for joining us on a Friday evening. Especially thank you to Dr. Gunn for coming and letting us talk about his study and giving us his insights, and Dr. Tummala and Dr. Kirkpatrick, and Dr. Cherry for joining as well. It's been great to have everyone here, and it's been fun working with Hannah and Thomas on this too. So thank you, everyone.
Thank you, everybody.
Great job, everyone. And I appreciate Dr. Tummala, Dr. Kirkpatrick, and Gunn for supporting this initiative and really, moving the needle in our specialty and showcasing to the future of our specialty kind of what it needs for us to kind of move the data, the science, the evidence forward so we can ultimately take care of patients better, not only locally, regionally, nationally, but also internationally. So thanks for moving the needle.
Thanks, Joji. Thanks, everyone.
Yeah, appreciate that. Thanks for having me. Really good job. Really good job, everybody. So good job.